Thank you very much for the opportunity to address you on this last day of NIC. I like that Ramesh gave me this talk because the real story is that I had the how do you manage pulmonary embolism more contemporarily before this talk, and I said, look, man, I do this much work well, and that's not one of those things that I do. So I can tell you a little bit about the Canadian system and how we do things a little bit differently than we do in the US, where money is actually quite a bit tighter than it is in the United States. And so this is more of a rational physiologic approach. It's not a ton of data, it's instead more concepts. These are my disclosures. Consider two representative cases, right? We're gonna bring shock into the cath lab. These are both mine. So this is what I call the sick but stable heart, 62-year-old non-STEMI and heart failure. Got an open lima, closed vein graft, EF of 20%. So not overly terrible anatomy. And you can see that there's a very tight ramus here that is the probable cause of this guy's non-STEMI. So my plan here, despite the poor EF, because no, it doesn't make sense to put support devices into everybody, I was gonna get in and get out. And of course, best laid plans, right? So the wire goes down, the patient starts becoming extremely ischemic, gets bradycardic, gets short of breath, starts complaining of chest discomfort, and we're in trouble. These were the pre-PCI hemodynamics. The heart rate was 100, the blood pressure was 95 on 70, so pulse pressure was borderline. The PA pressure was 60 on 24, mean 36. So this was already a decompensated scenario with a wedge pressure of 22. The cardiac index is 2.01. So clearly a low output state. Maybe not shock yet, strictly speaking, but a low output state at the beginning. Compare that to this case. This is the well heart, but the worrisome course. 58-year-old hypertrophic cardiomyopathy, has a recent successful ablation actually, and then comes in with some funny symptoms and decides to come in for another angiogram. And then of course, this is the first picture of the angiogram because there's a giant clot that comes out of the sheath in the leg, and upon engagement into the left coronary system gets injected down the left coronary. So that guy's course is probably going to be different than the first guy's course. How do we talk about these two patients in the same way? And how do we use that conversation to try to target our tools to the right patient? Well, this is the new shock classification. This was supposed to be a common language where we started talking about at-risk patients and how they differ from patients at the beginning of shock versus those who are in classic or deteriorating shock. And then most of us recognize the extremis patients where they're just circling the drain or going downhill quickly. But I ask you, if you look at the two cases that I just presented, they're both very sick patients, but where do they fit here? Who's a C, who's a D, who's an E, if they're in the throes of an acute decline? That's where we face the challenge about trying to target our devices, because in the super sick patient, it's pretty clear that they're going to need some sort of support, and they're going to need as much support as you can give them safely. For the not particularly sick patient, but who you know is declining in front of you, you need to pick something, but you don't want to overshoot the vasculature compromise that you're going to get with ECMO when a balloon pump will do. So how do you target these things? Well, it comes right down to the same goals that we put forward for any sort of shock therapy. Basic goals: improve systemic perfusion, because patients come with a reserve in all of their organ systems, and for every hit they take, we lose viability, right? That's this whole concept around elevate, not escalate. Don't wait for organ systems to fail before you start to increase the amount of support you're providing. Instead, give the patient a net, give them as much support as they need, and then start retracting that support as their body demonstrates competency against the biological insult, and do so in the safest way possible. The second goal is rest the heart. Right? Improve myocardial oxygen supply and demand. Try to reduce the amount of work that the heart has to do to fulfill goal number one, because any more work in an already injured setting means that you end up with a more injured heart in the end, not just the beginning. And this bears out, right? Because as we realize, as shock gets worse, people do worse. And there's a litany of papers now that show that the worse the SKY stage is, the worse your outcome's going to be. And so the message that this all gives you is the sicker you get, the more likely your outcomes are going to be poor, and therefore the more work you have to do to pull a patient back from the brink to safety or to an envelope where they're going to be able to recover. And so we modify the basic goals of therapy from systemic perfusion and myocardial rest to add in one more component, which is get control fast. Early and rapid reversal of hemodynamic collapse so that we end up with more organ reserve left. So how does that then affect which device we choose? Well, this is where the practicality piece starts to come in, because we recognize that 30-day survival rates from 2 decades of cardiogenic shock trials tell us the same thing. All of your wins are here, right at the very beginning, because the longer you wait, the more organ systems you lose. So this is the hemodynamic support equation that Naveen Kapoor put out some time ago. And this is a really smart slide that I'm sure many of you have seen, many of you have used, but I think it's actually worthwhile considering each of the individual components so that we can try to tailor a support solution to what our patient needs. Let's consider our first guy, where the problem was largely a sick heart, a poor baseline already. So this guy had systemic perfusion and has lost it transiently. The LV in his case was already badly loaded versus the first guy where the LV may have a degree of reserve. He started with a normal EF in the second case, whereas the first case was very, very poor. And then coronary perfusion in the first case was subject to ischemic preconditioning. We just happened to be in an effectively only remaining segment vessel that resulted in that hemodynamic collapse. Versus the second patient where almost all of the coronary perfusion was taken off completely. So as a result, if you're going to think about an individual where your priority is going to be to reverse the systemic perfusion insult, you're probably not going to worry about a device that's going to deal with your coronary perfusion optimally at the get-go, right? What you need to do is save the body. Versus for somebody where, like the first guy, your coronary perfusion is what you care about most because that's really what you've changed, then you may choose a different device. That might not be the guy you put on ECMO right away. You might think about something else. Right? So how do you develop a protocol to try to help yourself work through these things? Well, we've heard about a lot of different protocols. Here's the one that we use at our site, right? It doesn't look all that straightforward because it isn't, right? You have a shock team concept where you have individuals that are involved in decision-making very early that span a number of different areas of expertise, including heart failure, interventional cardiology, cardiac surgery, and intensive care. And all of these individuals bring their own knowledge to bear, bring their own interpretation of that mechanical circulatory support equation to try to give you an understanding of which way to go. And the reason that we need that shared decision-making model is this. There's a lot of questions that are open. We don't know a lot of stuff. Is it acute or is it chronic? Is this the decompensated heart failure patient with walk-in low output that decompensates further? Or is this the guy where I injected a bunch of clot into his left main? Is it happening at the start of a procedure? Is it an expected complication or is it a patient walking through the door? Is this a remodeled heart with an LV of 7 centimeters? Or is this an acutely decompensated heart where there's no preconditioning? Is it ischemic? Or is it valvular? Or is it underlying heart failure? And what's the shock phenotype? So this is now where we start to get into how to select a device. There are 4 key questions that you have to ask. Is it really shock? And if so, how bad is it? What is the baseline heart function, etiology, and shock type? This is going to the analysis of that mechanical support equation. What do you have, practically speaking, available to you? If you're in the cath lab, what do you have available in your lab? If you're in the ICU, how fast can you get to a place where you can implant a device? And what can the patient handle? So now we pull ourselves back to that SCAI shock classification and start to add a little bit of granularity. And that's this, right? Where we know that as SCAI shock stage progresses, you end up with worse outcomes. We know that these are sicker and sicker patients, the higher and higher you go. Using a large contemporary data set out of multiple centers in the United States called the Cardiogenic Shock Working Group, this has been developed where they took over 1,000 patients and they just analyzed all of the 2,200 data points for each of those patients to try to figure out how to parse this out. And what we recognize then is that your sort of SCAI stage C type of patient is the one that already has an important degree of organ compromise, right? Your lactates of 2 to 5 on one drug or one device. Versus D, where that's starting to progress into lactates of 5 to 10. Versus E, where it's lactates of over 10. And notice that B, C, and D all have about the same blood pressure. And that's why that's not a particularly useful concept. That's why we use things like cardiac output to conceptualize how bad shock is. Because blood pressure lies to you. The body's smart and it does a really nice job of compensating for vasodilatation or for poor cardiac output by vasoconstricting and maintaining output to the core. So This is just something to tell you about how heart failure might differ from acute MI, where as you progress in SCI stage, everybody gets worse. But what we learn is that at your maximum SCI stages, your acute MIs in C, D, and E have a much higher mortality than your heart failures. And this speaks to the importance of those compensatory measures. And what we understand is that when you have a hemometabolic shock state, where you've got a compromise in the body's systems, as well as a compromise in the heart function, your in-hospital mortality is so much worse. You have shock phenotype 1, which is just a heart problem. Moving forward to shock phenotype 2, which is a heart and kidney problem, right? That's your cardiorenal syndrome. Moving to phenotype 3, where now you have liver congestion, shock liver, etc. And so as you progress forward, you have to look at the different devices and see what problem they are capable of treating. Your balloon pump is good, and it's not a useless device, right? We have some people that respond very well to this device. It's fast, but downside is in order to counterpulsate, you need pulsation. The Impella, it's moderate support, it's reasonably fast, but it does require a larger access. Versus ECMO, where it's a full support with an oxygenator. But in high BMI patients, you may not get enough support, and it requires prep time and the priming of a circuit. And then, of course, there's this. This was my very first axillary Impella case, because this is what this lady's groins looked like. So there's the practicality aspect as well. What can the patient handle? So just as I conclude, this is how these cases ended. I ended up putting an Impella in this patient because I needed more support than a balloon pump would give me. I felt real good because I managed to do a hit and run and get out. Unfortunately, he died later that day from ischemic gut. He went up to the ICU, but that hit in the cath lab, because his disease was everywhere, took out a piece of his gut, he had a watershed infarct, and he perfed his bowel and died. And so this speaks to the importance of not messing around and making sure that you plan. And that might be our most important support device, our brains, so that we predict the problems from happening before they end up happening. Versus, and this was, by the way, this was the case 2 after aspiration. We managed to get flow down the left main. This is the guy where he injected a bunch of clot. He got worse despite an Impella being in place, so he ended up on ECMO and then actually ended up doing well. So for me, this is my IABP population. Relatively early shock, relatively modest LV dysfunction, where you still have a ventricle that can counterpulsate. Then comes your workhorse device, where you start taking care of the majority of SCI C shock and SCI D shock in its early phase, because that's when the problem is still a heart problem, or at worst, a heart and kidney problem, where you don't really need an oxygenator and you don't need to unload the RV. Versus here, where now you've got RV compromise, you've got LV compromise, and you're going to need biventricular support, plus or minus an oxygenator. That's how I select these types of devices. And just as a last thought, there's a reason why IMPRESS and similar trials have failed, because cardiogenic shock is a very heterogeneous population. And so it's important for us to recognize that there are some patients that go beyond where a mechanical circulatory support device can fix them, right? We don't have a device that fixes anoxic brain injury, which is how 50% of the patients died in some of these trials. And so it's important to recognize maybe it's time for a futility score, something to be able to tell us that our time is going to be best spent with the patient's family, helping them understand that unfortunately their relative will pass away. So for the cath lab environment, this is sort of the way I think about these things. This is my rapid deployment device selection algorithm. IABP, early shock, where I expect there to be a quick fix in place. Versus VA ECMO, profound biventricular shock with hypoxemia, the RV down, or we're in multi-organ failure. That's that SCI phenotype shock 3. Versus Impella, where that's your workhorse in AMI cardiogenic shock, deteriorating LV shock, or in individuals where you feel like you're going to get a fix, but the effect is going to last for a day. Thanks very much for your time and attention.
Thank you very much for a fantastic presentation. We do not have that much time for discussion.
Apologies
because we have some delay, and we'll go to the next presentation by Ramesh.